Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. This episode's guest is Dr. Sarah Cope. Dr. Cope is a consultant clinical psychologist at St. George's University Hospital, NHS Foundation Trust, as well as Southwest London and St. George's Mental Health NHS Trust. She is an accredited EMDR and CBT therapist. We discuss her pathway into FND, the basics of EMDR therapy, protocols, mechanisms, targets, etc., the use of EMDR in FND, specifically her MODIFI trial. We were fortunate enough to be able to discuss the MODIFI trial results, which have been accepted for publication in the Journal of Neurology and should be available at the time we publish this episode. See links for these articles in the show notes, and I hope you enjoy my enlightening and encouraging conversation with Dr. Cope. Recording. Great. Well, thank you so much, Sarah, for joining me today. I really appreciate you taking the time, especially over the beginning summer months when time is valuable, even more so, especially here in Chicago when the weather's finally nice and no one wants to be indoors. So that's great. If you could start by telling our listeners just a little bit about your academic background, how you got into FND, just kind of introducing us to your work and your world, that would be great.
Okay. Thanks for inviting me, Erica. So I trained at UCL in London, my clinical psychology doctorate, and my doctoral thesis was looking at pain. I did an experimental study manipulating how much empathy someone felt their partner was feeling for them when they were in pain, and also looked at their attachment styles and how that impacted on their subjective pain report. So I guess I sort of had an earlier interest in psychological and social factors and how someone experiences their body and their health. Initially, I worked in kind of general mental health. So I worked in a community mental health team, which I'm not sure what the equivalent would be in the States, but it's kind of secondary care, sort of more complex presentations. And I also worked in a primary care psychology therapy service, so anxiety and depression, so more straightforward presentations. I was always more drawn to more complex presentations. I had a patient with FND within the CMHT, never heard of it before, had to do lots of reading, didn't know what I was doing, kind of tried my best. I mean, he was quite a complex presentation, sort of psychiatrically, and also had FND symptoms and dissociative fugues. But really interesting and really good to work with him, and, I guess sparked an interest in the area. And then I happened to see a job come up in the neuropsychiatry service at a hospital called St. George's in London. And it looked really interesting. And I thought, well, I'll have a go, I'll apply. And the job was actually created because it was just before the CODES trial was starting. And St. George's wanted to be a recruiting site, but they didn't have anybody who could deliver the CBT therapy. So they created this clinical psychologist post in the service so that they could deliver the CBT therapy. So yeah, I joined the service on that basis, initially part-time and eventually full-time. And obviously I had the CODES training and was a CBT therapist on that trial. And so I guess exposed to trial experience there as well, and enjoyed that process. And so, yeah, and then within the service, because I was their first psychologist sort of setting up a psychological therapy pathway, I was lucky to have a really supportive and enthusiastic colleague called Dr. NIHR Agrawal, who's a consultant neuropsychiatrist. And we worked together to create groups and a pathway for patients where there really was very limited treatment options. And then I became interested in kind of, what other therapies might be helpful for this patient group. So I tried sort of acceptance and commitment therapy. I looked at EMDR and thought, okay, well, that sounds interesting, a bit odd, but maybe worth going on the training. I went on the training and I really was quite skeptical about it. And then as part of the training, you do have to have an EMDR processing session yourself. And I was really quite surprised by my reaction in it. You know, I'd picked a memory that was, you know, distressing, but not hugely distressing anymore. It was a coach crash when I was traveling. And I think I rated my distress as, well, my subjective sense of disturbance as 4 out of 10, where 10 is the high disturbance and 0 is no disturbance. And, you know, what came up in the processing was a very physiological reaction. I was sweating from head to toe. And also where my mind went was quite surprising. I ended up being taken to memories of my dad dying, which was relatively recent in terms of the timeline of that accident. And I thought, gosh, you know, and within the processing, you have some control over where you go. So, you know, obviously I was in a public place. This was not, you know, my personal therapy. So I did rein myself back, but I thought, goodness, that's a bit surprising, especially for someone like me who likes, you know, likes to be able to explain things. So I realized that actually this could be really useful with the patient group, but that it needed to be used carefully because it can be surprisingly powerful.
Powerful tool that taps into seemingly certain elements of brain processes that are not always voluntarily known, aware, sort of at the surface.
Exactly.
One point of clarification, you said a coach crash. Just what is?
Oh, sorry. Yeah. A coach is like a big bus.
Okay.
Yeah.
Got it.
What was, yeah. Okay.
I was like, is that a car? Is it a train? I'm sure she doesn't mean horse and carriage.
Oh, it's funny.
It's great.
Okay. And so I just started using it in my practice really carefully. You know, as part of your training and your use of EMDR, you do need to attend regular specialist EMDR supervision. So I was seeing an EMDR consultant for supervision. They didn't have a lot of experience in FND, so it was kind of just trying to work out how to use it. And so I did, and then kind of got to 2020 and I thought, you know, I really would, my initial motivation actually was I really would like some more staff in the service. I'd like to have more psychologists.
Don't we all? It's a good ambition.
Maybe I could, you know, the problem is the evidence base is a bit lacking. You know, we need to have more evidence that psychological therapy can be helpful for patients with FND. So I started to talk to Mark Edwards, who was professor of neurology there at the time, and connected with some other colleagues, Sharif El-Levy, who sort of is expert in sort of PTSD, and Jared Smith, who's an academic psychologist and statistician at the university. We came up with a trial design and submitted an application for funding with the NIHR, and then got through the first stage and then submitted the second stage. And I found out that we got the funding when my baby was 3 weeks old, so then had to delay actually starting the trial. But
oh my goodness, what a whirlwind!
So it's been a bit of a whirlwind. So we started back in 2022, and we've recently completed the study. And the results paper has just been accepted for publication. So that's really exciting.
That's a wonderful trajectory. Sort of a rocket ship up to, and now you had a patient with this, you get curious, then you look out other interventions, and then suddenly you're doing a full controlled trial and getting results. So it's an amazing trajectory in a short period of time, and having a baby to boot.
Certainly not planned. But I guess, you know, FND is an area where, there has been a huge explosion in research and interest, which is fantastic in the last sort of 10 years or so. But it is still an area that there's a lot of gaps in our knowledge. And a lot of research needs to be done.
Yeah, lots of work to do. I definitely we'll definitely circle back for our listeners hearing about the trial and the results of the trial, especially. I feel so privileged. We get a sneak peek before it's even published, although by the time this podcast is probably released, this that article will probably be available. But before we get there, if you could just lay some of the background pieces, I think, to help people kind of understand in context your trial within the FND population. So when it comes to the FND population, the different subtypes, we have functional seizures, functional movements, triple PD, functional cognitive, who you would see EMDR being applicable to. Are there any limitations from a population perspective, and then from a comorbidity perspective or a severity perspective, and the timing of that? Do you do EMDR before other functional interventions? Are you processing body symptoms related to FND? Are you processing body symptoms related to trauma? How that decision gets made, and any other thoughts around sort of mechanisms? I know I just asked a lot of questions in one, but I'll remind you of those different pieces. But if we could just kind of cover those basics before then we dig into all the nuances of the trial.
So I think that, when I started thinking about EMDR, the obvious place was functional seizures, because of the higher likelihood of associated PTSD and trauma. But I kind of quickly found that actually it could be used for other presentations too. And I think if we think back to what is EMDR therapy, it's a therapy that focuses on distressing or traumatic memories. And although it's been widely researched with PTSD and has established efficacy for treating PTSD, which is a disorder characterized by someone having experienced what's referred to as a criterion A traumatic event, so something life-threatening and serious, it can be applied to other memories that are not criterion A events. So it has quite kind of broad use, really. I mean, it's increasingly being used for chronic pain. There's evidence emerging for its usefulness in personality disorders. You can use it for tinnitus. You can use it for adverse medical events. So because it is a therapy that's focusing on memories, and the model behind it is really general and not really testable because it is so general. But it's the idea that during a distressing or traumatic event, memories are sort of stored incorrectly in this kind of frozen dysfunctional state, and they don't have access to more adaptive material. And that those memories are what generate sort of dysfunction in terms of beliefs, in terms of behavior, in terms of physical symptoms, and that by targeting those memories, you allow kind of movement in the system and adaptive material emerges, and the person is then no longer distressed by the memory. And also actually in terms of experimental studies, they've shown that vividness reduces with memories. So thinking about that as a general theory, I don't very much sort of think about it in terms of which FND is this applicable to. It's more, what is this person's formulation? How did they get to this point where they have FND symptoms? What is their story? And how can we think about what's maintaining their difficulties and what's sort of contributing to that development? So yeah, less and less. And I think maybe also because I tend to work with complex cases. I mean, I can't remember the last time I saw someone with only one functional neurological symptom. So people tend to have more than one. So yeah, I think that if there's any distressing memories associated with someone's FND, associated with the start of it, or consequences of it, or the kind of a traumatic event starting beforehand, then you've kind of got a way in where it might be useful. EMDR can also be used for memories in the past that might connect to something in the present. So an example of that might be someone's experience of the FND symptoms sort of evokes feelings of maybe helplessness or danger. And these feelings might be linked back to earlier experiences of that. So then you would have a kind of a choice point in the therapy in terms of, do we stay focused on the kind of FND memories, or do we need to go further back? Yeah.
Okay. So if I am, just for our listeners, if I were to summarize back in fairly layman terms, I think, correct me if I'm misrepresenting. So the way I'm interpreting what you're saying, perhaps as a bias from my brain-based background. So in instances of more extreme distress, brains have a tendency to have heightened reactivity, including physiological response. And at the time, that heightened emotion is not very well processed, not very well connected to context, adaptive features, adaptive outlets. And so that heightened emotion and physiological response may be stored as a memory that's less adaptive, and a heightened sort of unprocessed memory and physiological response. And EMDR facilitates tapping into that, generating a reduced intensity by connecting it to other parts and principles more in the present, more adaptive, reduced body state, which then allows that memory to get sort of restored in a more comfortable, integrated way that allows for greater adaptation. And that for EMDR and FND, that can be FND, the emotional reactions and sort of experiences that go along with the fear of having FND, especially prior to diagnosis and knowing what the heck is happening. For a lot of people, that is a very traumatic experience, normatively so. And then also being able to connect that back to if that FND experience is being connected in sort of these nodes of connection, right? Where there's then other more intense emotional experiences that haven't been processed that are leading to a heightened bodily response or excess emotional response, that all can be targeted sort of in a node-like fashion, or sort of breaking down a system or a connection pattern that then helps the whole system function in a way that has less intensity, more physiological control, and less negative activation. Is that seeming helpful?
It's a really good summary.
Awesome.
I think also thinking about predictive processing and that memories must, logically be part of creating those kind of priors. So I think that there's something around influencing someone's memories of the start of their symptoms, and whether that can help to kind of dislodge these unhelpful predictions. I mean, that's just theoretical, but I think it's an interesting idea.
One piece with that, the predictive processing and the utility of changing someone's expectation around what that memory might mean, or what those aspects might mean, and adding those more helpful elements that help with regulation, that sort of frontal regulated control of the emotions and experience and expectation. With that said, could you walk us through, I know it's probably very complicated and different for different patients, but the core practices for EMDR, how is it explicitly done? Or do you think it's easier to talk about this in the context of your trial? And was your trial different than the traditional, I guess, is
good question. Part of that. So EMDR does have a standard protocol, and it's an 8-phase protocol. I won't talk about it in huge detail here, but the first two phases are about assessment and history taking and formulation and stabilization before proceeding with processing. And the next couple of phases are around processing, which follows a standard protocol. And so, for example, you would, with the patient, agree a target memory. You'd ask them to bring it to mind. You'd ask them, what's the worst part of that memory now? When you think about it now, what's the worst part? They would tell you. Then you would ask, and when you think about that, what's the negative cognition that you have about yourself now? So not what they might have thought about themselves then, what they think now. And then you ask, and then you think about that. What positive cognition would you prefer to have about yourself now? So that kind of gives a direction for the person to kind of think, where do I want to get to with this? And that can often be harder to generate. So an example of a negative cognition might be something like, I'm not good enough, I'm going to die, I'm helpless, I'm inadequate. A sort of strong negative cognition generally starts with an I am statement. And the positive cognition might be something like, I can handle this, or it's over now, or I'm safe now, or I have choices. And you agree kind of what sort of fits best, and then you ask them on a scale of 1 to 7, where 1 is completely false and 7 is completely true, how true is that positive cognition to you now when you think about the memory? If it's only 1, it's not really a very good positive cognition. You need to get something that they can believe a little bit. And then you also ask them, when you think about the memory, how disturbing does it feel to you on a scale of 0 to 10, where 0 is no disturbance or neutral and 10 is the highest disturbance you can imagine? And where do you feel that in your body? And you also ask for associated emotions. Missed that bit out, sorry. And then you start the processing, and you ask the person to bring the memory to mind and the negative cognition, and traditionally follow your fingers in front of their eyes. But really you can use any bilateral task. So you can use tapping, you can use bilateral sounds. There's also studies that show you can use non-bilateral tasks. I mean, I'm not sure whether you want to get into a conversation about mechanisms, but yeah, so the idea is that the person is paying attention to the memory and also paying attention to this other task. And then after a number of sets, you ask them, what did you notice? They tell you, don't discuss it. You're trying to keep the person very much in an emotional kind of zone. And you just say, go with that, or notice that. You do another set, you keep going. And you're waiting for adaptive material to emerge. With more complex presentations, you do need to use other strategies to help someone kind of move through the material, which are probably a little bit more complicated to talk about now. But you're trying to access that adaptive material, and you're trying to get them to access it, importantly. And then when disturbance is down to 1 or 0, you then install the positive cognition, and you look for any remaining distress or disturbance in the body. And again, using a bilateral task, processing that. And then that memory's finished.
That's great. And then it's reduced its intensity and replaced with...
and generally processing occurs between sessions. And often a memory will take more than 1 session to process. So you're not necessarily going to complete a memory in 1 session. But it can be surprisingly quick, and patients can report that they're surprised. It's sort of like, oh, why does this feel
this is
less distressing to me?
Reduced.
So going back to your question, so there is a standard protocol. And we use the standard protocol within MODIFI, but we did incorporate FND education and formulating around the FND symptoms in the kind of phase 1 and 2. So it's very FND focused, EMDR.
Yeah, sort of sticking to the EMDR general protocol, but with adaptations for FND.
Yeah,
great.
Exactly.
Excellent. Slight quick question on the mechanistic piece without going. I know we could get into so many different avenues. We could spend a whole this podcast on discussing EMDR mechanisms. The 2 core mechanisms, or I think pieces that you brought up, there's obviously the 3 pieces of identifying and connecting to body sensations, but then the role of the extinction response, essentially, where they're continually bringing up the negative memory, the negative cognition, simultaneously paired with the bilateral, usually visual or sensory stimuli. I've also heard of like buzzers and alternate hands, where there's kind of a sensory input, or a colored light or things like that. The mechanism I'd love to hear from your perspective, the mechanism of that exposure, extinction, processing, and bilateral, and the role of that, and how that contributes to the decrease in reactivity or intensity of that memory. I think that's kind of probably the core.
Yeah. I mean, I think exposure to the negative material, absolutely. The more someone's exposed, the anxiety reduces. But I think there is more to it than that, in the sense that you're sort of facilitating the process. So the bilateral task, and one of the theories why that, or bilateral stimulation as they refer to it in the literature, one of the main theories is the working memory hypothesis. So the idea that when someone's bringing the memory to mind and having a competing task, and the memory has to compete for space in the working memory, and it goes back in an altered form. And I think that there's definitely, in my experience, my opinion, I think that definitely has good validity in terms of an explanation. And I think particularly for more PTSD-related memories, where they're really intrusive and really distressing and disabling to bring to mind, it kind of helps someone keep with it. I think another thing that's going on is that idea of one foot in the past, one foot in the present. So keeping someone in their kind of window of tolerance, so not getting too distressed, but also not zoning out, switching off. And within EMDR, with the FND population, you do need to monitor dissociation and manage that within sessions, because obviously that's a common occurrence. And I think that the other theory is the orientating response, the idea that when you're getting someone to bring up distressing material and also focusing on the competing task, and it's neutral. So they have an orientating response, and then that distressing material becomes associated with a neutral stimuli. And the other theory is the rapid eye movement theory, the idea that the eye movements are in some way mimicking REM sleep. I mean, I'm sure that there is evidence for that potentially, but my perspective is that I often work without eye movements, so then that doesn't explain why it works. I'm often seeing people online, and we use tapping and alternate methods. So,
So if I'm hearing correctly and understanding or reflecting back, several pieces are actually pretty well mirrored to some of, I think, the traditional FND approaches, where there is tapping into the inherent limitations of the brain to process more than one thing at one time, and doesn't have infinite, so they can't infinitely feel this extreme distress and process some external task. And so there is utility in that if being directed to process an external task, the intensity of the thing on the mind, that memory, et cetera, will inherently be reduced. There's just less resources to attribute to that and feel that at the same intensity, which is excellent. And we tap into that with FND all the time, with distraction, competing motor movements, et cetera. So I think that's very intuitive. And we're sort of using the same principles just for a traumatic memory, although also it seems like in the protocol, which we'll talk about, also tapping into FND. But then also this lots of aspects of grounding, right? Where there's the experiencing of a traumatic memory or pulling something difficult to mind while being in a safe present, right? A safe present or a neutral present, and engaging with that safe or neutral present that sort of allows that memory to be sort of reintegrated or connected to safer, more calming, more grounding present aspects, which inherently changes the relationship to it, almost in sort of a restorative or corrective experience of that intensity of feeling memory within a more safe present. If I'm reflecting back correctly, do you think?
Yeah, I think that's part of it. And then, of course, the associations that come up during processing, which I kind of mentioned at the beginning, which doesn't happen for all people, but for some people it does, and they can be really useful in terms of making links about why this experience was so distressing for me. What does it link back to?
Wonderful. Now, I think we have a great background to, now that our listeners are fully versed in terms of FND and EMDR, how your protocol for EMDR and FND played out. So what was your protocol? And then sneak preview, because we're very lucky and very grateful that you're able to share some results with us.
I'm sure. So in terms of our, let me just clarify, you're asking about the research protocol rather than the treatment protocol?
Yeah.
Okay. So we recruited 50 participants from a single site, so from the neuropsychiatry service at St George's Hospital in London. And participants needed to have functional seizures and or functional motor symptoms to take part. And we randomized them to either receive EMDR plus standard neuropsychiatric care, or standard neuropsychiatric care alone. The EMDR consisted of up to 16 sessions in a 6-month period, with an optional follow-up session that didn't count towards the EMDR sessions. The standard neuropsychiatric care was standard care offered in the service, so 1 to 3 outpatient appointments with the neuropsychiatrist, and they were also offered to take part in any group interventions that we offered. So there's an FND education session and also a functional seizures group. So participants were invited to that as they would normally be if they were patients in the service. We assess participants at baseline, 3 months, 6 months, and 9 months. This was a feasibility study, so it wasn't powered to establish efficacy, but we did embed sort of clinical outcome measures in there, we looked at we got participants to choose up to 2 symptoms that they were going to rate throughout the study, and then we used something called ecological momentary assessment via an app. So for 2-week periods at each time point in the study, they would rate their chosen symptoms in terms of interference, distress, and preoccupation, and severity. And also with functional seizures, they would rate the frequency. So every day for 2 weeks at each time point, they would rate their chosen symptoms, and they kept the same chosen symptoms throughout the study. We also looked at disability, quality of life, depression, anxiety, PTSD, dissociation, and healthcare use.
Those are a lot of different things to consider. I have one follow-up question about the app related. So they did that for the 2 weeks at the start and then at the follow-up as well?
Yeah, so every follow-up, so 3 months, 6 months, and 9 months.
Perfect, yeah. Great. And then it's interesting. So your group chose, probably because there's such heterogeneity across them, doesn't matter what your symptoms are, how many there are, or the nuance of right arm versus left arm tremor versus right knee buckle versus whatever, just whatever your symptoms are, how bad would you rate them? How impairing are they? How distressing are they? Sort of regardless of what's present, sort of neutralizes or equalizes underlying symptom presentation and how we would objectively rate it. It's more subjective.
Exactly, subjective rating. So they would choose to rate their functional seizures, or they would choose to rate their weight weakness, or they would choose to rate their tremor, or a cognitive symptom. So they chose what they were going to rate. Yeah.
Was there a limit on how many they could pick?
Up to 2.
Up to 2. Okay. Yeah. So just you're honing in on pick the 2 biggest kind of ones. Awesome.
And interestingly, only 3 participants out of 50 chose to rate only 1.
Huh.
So it just sort of shows, what we do know, that FND presentations are heterogeneous, and generally people have more than one symptom. Yeah,
there's facets to what the pieces that are concerning. Yeah, great. Yeah. And then your protocol, 16 weeks. Was it a single?
16 sessions within 6 months.
Yeah. Was it one therapist, multiple therapists?
So we had 2 trial therapists. So both attended sort of some training with me in terms of delivering the therapy protocol, but they were both EMDR trained, and then throughout the trial they attended EMDR supervision with an EMDR consultant, and I also attended that supervision. And within the supervision, we particularly focused on kind of the formulation and target selection in terms of, you've only got 16 sessions, which memories are going to be best to focus on. Yeah.
Could you highlight what the FND modifications were from a traditional EMDR protocol, if those modifications stood out?
So I guess traditionally in EMDR, you go for the first, the worst, or the last in terms of a traumatic experience. But we applied that to FND, really. So it was the first, the worst, or the most recent experience of FND. And we also, of course, screened. Oh, I should say, actually, in our one of the measures that participants completed at baseline was the ITEM, the International Trauma Exposure Measure. So that looked at exposure to traumatic events across the lifetime. And it measured both criterion A traumatic events, so things in line with sort of DSM-5 diagnosis of PTSD, but it also measured psychologically threatening events, so in line with ICD-11. So quite a broad trauma exposure measure. So things like bullying, neglect. Yeah.
Great. Any other notable changes? And what would you say that for FND, was there more focus needed on the therapeutic window? Were individuals with FND, in your experience, more likely to need reduction or longer processing or differences in processing to stay in a therapeutic window without provoking symptoms, or was it generally well tolerated?
We found it was generally well tolerated, and we would conceptualize FND symptoms within the processing as you keep going if you can. So you wouldn't stop because of that.
Great. So if they had their symptoms, then it was just, we'll carry on with the memory and with the process, and unless it was
possible. Yeah, if possible. Because I mean, that's also an important learning for someone.
Yeah, to carry on. Great.
Yeah.
Are you able to talk through any of the results? Which I feel very privileged to be able to hear at this point. Pre-published results is what a joy and a treat.
Yeah, sure. So just thinking about our sample in general, so 64% chose to rate functional seizures, 80% functional motor symptoms, 44% had both functional seizures and functional motor symptoms, and a third of the participants chose to rate cognitive symptoms. So quite a broad presentation in terms of our participant sample. And 40% of our sample met PTSD. And that was assessed using the International Trauma Questionnaire. So, not as good as doing an clinical interview, but giving an indication of PTSD. And the International Trauma Questionnaire is in line with ICD-11 diagnostic criteria. And the questionnaire also assesses complex PTSD. So actually a high proportion of those who met criteria for PTSD also met criteria for complex PTSD.
So sorry to interrupt, as a point of clarification for our listeners and myself, just so EMDR, historically, everyone thinks trauma therapy, right? But you did not select individuals with FND with a focus on histories of trauma, where you only selected FND if trauma was prominent or paramount. You just selected FND broadly, just if they had run-of-the-mill FND, if that's a thing, sort of typical FND. And then incidentally, you found 50% met criteria for PTSD or complex PTSD, incidentally, just out of a typical FND sample. And then you applied the typical EMDR. Wow. Okay. I think that's very marked for people to know, is just the high prevalence. I mean, we've always heard of trauma as a comorbidity, but just how high.
Yeah. I mean, I think it's similar to other studies in terms of the proportion. Our inclusion criteria also were that a person had to endorse at least one traumatic event on the International Trauma Exposure Measure. I mean, no one didn't.
It wasn't there wasn't a large number of people excluded for not having that.
Nobody was excluded for that.
Oh, sad.
Yeah. I mean, actually, the mean number of traumatic events that our participant sample were exposed to was 8 across the lifetime. Four of those, a mean of 4 for criterion A and a mean of 4 for criterion B. So quite a high traumatic exposure.
Yeah, just high burden. Okay, great. Yeah. Thank you for that clarification. So you were not pulling for trauma, but there was certainly a significant representation of trauma within a normative FND sample.
Yes, yes. But actually what we looked at as well is what memories do participants select to work on? And actually 2/3 accessed both FND related memories and non-FND distressing memories. Only 5 participants out of the 24 in the EMDR arm chose to focus on non-FND memories. So it kind of really demonstrates that you don't have to focus on necessarily, even if present, the non-FND memories. So in terms of our results, we had it was feasibility study, so we weren't testing for significance, but We did find that the EMDR group had a bigger improvement in terms of their FND symptoms, better mental health, reduced disability, and also reduced healthcare costs.
Wonderful.
And yeah. Yeah, so we had good signals of efficacy. But in terms of the feasibility outcomes, which I should have started with, was that, we did establish that it would be feasible to carry out a larger scale trial. So we had good recruitment, treatment adherence, and retention to the trial. And it seemed to be acceptable to participants, and it was safe to deliver. In terms of our kind of adverse events and adverse reactions, they were not unexpected. So we didn't think they were due to trial participation. The adverse reactions that we had in the context of EMDR were things that we expected. So things like someone's FND symptoms temporarily increasing after a session, for example.
Right, but no significant decompensation, psychiatric hospitalizations, or persistently worsened FND symptoms. If anything, the opposite, where temporarily increase immediately during or after, but then actually improving over the course of exposures and treatment.
Yeah, and we only had 2 withdrawals from the EMDR arm.
Wow.
And I think that so it was well tolerated by most people. The 2 that withdrew, it was difficult for them, and so I think we do need to acknowledge that it is a hard therapy to go through, and for some people it will be too difficult to do.
Yeah. On that note, what do you think are, or what were part of exclusionary criteria, or what you would say going forward are contraindications for attempting EMDR with an FND population?
So we excluded participants if they had a dissociative identity disorder, and also if they scored above, they scored 15 or over on the multi-scale dissociation inventory. There's a subscale on that called identity disturbance. If they scored above 15 or over on that subscale, then we excluded them. There was an error in the database at the beginning, and we actually did include 2 people who shouldn't have been included, and they had scores of 15 of identity disturbance. But we made a clinical decision to still keep them in the trial because they didn't have a diagnosis of dissociative identity disorder. And actually, one of those participants was randomized to EMDR, and they did really well in treatment, and their identity disturbance reduced down.
Wow, that's great. Did you? I'm assuming...
So I would, yeah.
Go ahead.
Sorry. So someone with identity disturbance specifically, dissociative identity disturbance, I would exclude from EMDR in sort of routine practice. But there are therapists out there who are very skilled at working with identity disturbance, and I think if that's your experience, then sure. But if it isn't, I wouldn't. I think you're going into dangerous territory. We also excluded people who were actively psychotic, suicidal, who had an eating disorder diagnosis. We included people with comorbid epilepsy, as long as their seizures were well controlled. And we also included people with comorbid chronic pain or fatigue, as long as FND was the dominant difficulty.
Substance use and self-harm?
Yes, we excluded people with substance misuse.
Yeah. I'm curious, just here in the U.S., especially with more states legalizing cannabis, how do you where did you stand on cannabis inclusion or exclusion?
Interestingly, well, of course, people don't. The substance misuse, would have had to come up in the sort of psychiatric assessment. People don't always disclose, do they? I can definitely think of one participant who was using cannabis during EMDR therapy, and the therapist sort of negotiated with them to not use it for 24 hours before therapy and 24 hours after. I think you need to be realistic about these things.
Yeah, exactly. I think that's a big part of especially practicing in the U.S. at this point is, at what point do we even call it a disorder or a misuse? If it's sort of an excessive coping tool, then definitely we would consider it probably somewhere along the lines of more abuse. But it's hard to have true addiction to cannabis is challenging to fully get physiologically, but as an abuse of this is a coping tool that they're relying on that's unhealthy, yes, but that's a trickier one versus obviously alcohol abuse and things like that are more readily identified or delineated.
Yeah. I mean, I
Yeah.
think with EMDR, you want someone to be feeling the feelings. So you don't want them to be heavily sedated or,
Yeah.
not being able to access
Blunted
their
in any way.
emotions.
So like
Yeah.
daily cannabis use would be a contraindication unless, and even if discovered, then negotiating that piece. Yeah. Yeah. Okay, great.
Yeah.
That's wonderful. Those are very promising results. So can you, it might be a little preemptive, but next steps in terms of broader randomized, fully powered randomized control trial or comparison groups? What's your group thinking with that? And just wonderful work. I'm just so thrilled to hear this and have this option be available for patients. It seems to have a lot of utility and high sort of safety and tolerability, which is amazing.
I should say that participants in the EMDR arm also rated, in terms of their symptoms, they rated a good outcome, more likely than in the standard care arm. So just thinking of the figures, but I think, so good outcome on the CGI. So very much improved or much improved.
Those are great scores. 1 and 2 is a solid outcome for an intervention. That's excellent. That's very exciting. Congratulations on that monumental work. And there's always needed more and greater interventions for people with FND. Moving forward, in next thoughts in terms of comparison groups, larger scale trials, what are you thinking? Take a break, focus on being take a break and focus on being a mom, because apparently that would be a valid thing for your life as well.
Yeah, I mean, it's been a lot of work and been quite consuming. Yeah, so there's a few things I need to finish up for the trial, and I've got a qualitative paper I need to finish as well. A larger scale trial, multi-center trial would be, is the obvious kind of next step in terms of testing efficacy. I think it will be challenging because, not everyone's trained in EMDR. So kind of having enough people trained, and then also kind of ensuring fidelity to the therapy. And we did record our therapists, and we did have a random selection of recordings rated for fidelity. In terms of a comparator group, I mean, it's whether you go for something like CBT, or whether you go for something sort of softer like supportive counseling, or even thinking about the kind of formulation and education element that we included as part of their therapy. What if you just did that and didn't do the EMDR? I think that would be quite interesting, because certainly in my clinical practice, whatever therapy I'm doing, I think a big part of it being helpful for someone is them understanding their difficulties and how they developed and how it connects to the past. And of course, understanding sort of predictive processing and attention and those kind of mechanisms.
Yeah. One population that came to mind is, as you were speaking about this, in the US, we have such a high we have a large military population, right? And then just kind of the rates of trauma in that population are extremely high and often highly comorbid when it comes to FND. In your view, what do you think the applicability is for? Well, one, were there any service members in your population, or was that an exclusionary criteria? And then two, what do you think the applicability or feasibility might be for those with military histories?
Yeah, good question. It's not something we recorded about our sample. Off the top of my head, just sort of thinking of knowledge of the participants, I'm not aware of anyone in particular with a military background. But I think that the use of EMDR is used with veteran populations already with PTSD. I certainly have heard of over the years of veterans who have PTSD and FND. I think that it could potentially be a very useful part of their treatment, particularly if they might have PTSD treatment and they're still having their symptoms. So then there's something else going on there in terms of keeping it going. Yeah.
Yeah, exactly. I'm just thinking through, in the US especially, there's providers whose whole entire practice is with military members or veterans, and it's just such a complex population to work with, but just the rates of trauma are very, very high, and this might be a particularly suited intervention for them. And just
some patients prefer it because they don't need to talk about in detail what happened to them.
Yeah, that's wonderful. This is great. I want to be mindful of our time too. Gosh, it just flies when I think we're continuing to have fun. This has been very useful, I think, to open our listeners to the world of EMDR and what a great introduction, and specifically applied to FND. And there's such a nice overlap between EMDR targets and FND targets and the mechanisms, and going straight to, and then you did a study and then you have results. And isn't this great that you can see, the early stages.
Potential.
Yes,
potential
exactly. We're not at efficacy yet. We're not at effectiveness.
We're not there at all. Yeah, just a feasibility study.
Right. You did a solid feasibility study with very promising results that I think has continued broad applicability. So amazing. Thank you for sharing this with us and our listeners and taking the time, especially, as I said, on a summer, just so everyone's aware, we are recording this on a summer Friday. Which, if that's not dedication and generosity, I don't know what is. Especially, at least if the UK is anything like Chicago summers, it's like we get two kind of months that are very pleasant, in which we try to optimize our time outdoors and not working as much as possible. So even more gratitude. So thank you so much for sharing this with our listeners and all the wonderful work that you're doing. It's just really looking forward to it. And for our listeners, we will probably this will be released by the time that article is published. It's been accepted, so we'll be sure to keep an eye out for that and include it in the notes for the session. So thank you so much, Sarah. This is just wonderful work and great to have our listeners be able to hear it straight from you. Thank you.
Thanks very much, Erica.
Physicians and providers treating functional seizures, we invite you to participate in a brief survey examining driving recommendations for patients with functional seizures. Developed by a dedicated study group, this survey seeks to capture the current opinions of physicians worldwide on this topic. Please take a moment to share your experience. A link to the 5-minute survey can be found in the show notes.